Conversations on MS. Thank you for spending your evening with us. We're here to talk about MS with Dr. John Corboy. I'm Kelsey Morrow, Education Manager at the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Bristol Myers Squibb and Genentech. This speaker series is just one piece of our education programming. We have a variety of formats available, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. Some recent videos include our Spring Education Summit, which covered the topics of spasticity, current clinical trials, the potential of stem cells in MS, and treatment philosophies over a lifetime. Recently, we also explored the why behind MS through genetics and environmental factors in a webinar, which can be found on our YouTube channel. We announce all of our educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. All of our education programs are free of charge to anyone interested. And now I'll introduce you to Dr. John Corboy. Dr. Corboy is a graduate of University of Pennsylvania and did his neurology residency there, with a fellowship at Johns Hopkins University in Baltimore. He specialized in MS and neurovirology at the University of Minnesota Medical Center before coming to Colorado in 1994. In 1997, he founded the University of Colorado MS Center, now transformed into the Rocky Mountain MS Center at University of Colorado, a multidisciplinary group offering state-of-the-art care and research to MS patients. Dr. Corboy is the director of that program, as well as our medical director at the Rocky Mountain MS Center. We had a lot of really great questions submitted at registration, and we'll get to as many of them as we can tonight. Again, you can ask new questions, typing them in the chat box. Today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. And with that, I'll turn it over to you, Dr. Corboy.
Thanks very much, Kelsey. I appreciate that. And everybody, this is very informal. So if you have questions, as noted, please put them in the appropriate place in the chat or elsewhere we can get to the Q&A. And if it's relevant to what I'm speaking about that time, I'll try and tie it in. If it's a separate topic, which is fine also, then I'm happy to actually, get those to those separately. As Kelsey mentioned, we do have a number of questions that were pre-submitted. I'm going to focus on those. And I really just have a few other comments right now. And so thank you. It's nice to see all the friendly faces, seen some of you before, some of you many times. And actually, I saw that we have a special guest on tonight, Connie McMenamin, one of our former NPs who retired about 4 months ago, is joining us. So if I say something stupid, Connie's going to correct it for me. So just a few comments before we get to the questions. One big topic for us all the time is diagnosis of MS, diagnosis and misdiagnosis of MS. And we've been formulating and reformulating the formal diagnostic criteria for MS over the course of realistically over 100 years, but in a more modern manner, probably over the last 30 to 40 years. And we are going now with what we call the McDonald criteria that keep getting revised. We should get a new revision of the criteria sometime very soon. I think it's going to be really run out formally at our major meeting in Europe called ECTRIMS, European Committee on Treatment and Research in MS. It's in Copenhagen in September. And that's where they'll roll it out. And they'll roll out perhaps some newer, better, faster ways to make regular diagnoses. They might change some of the diagnostic criteria for primary progressive MS. We may include radiologically isolated syndrome. That is the first potential signs of MS that are seen only radiographically when someone has not had typical first symptoms of MS, maybe some vague symptoms like fatigue, but nothing specific like numbness from the waist down or loss of vision in an eye. And so the reason why that might be added is because there are now several treatment trials in people with radiologic isolated syndrome, or RIS. And they show that even before people have had symptoms that are typical for MS, that treatment for MS significantly delays the first clinical attack that we think that is typical for MS. So with treatment data like that, it's going to be very difficult to argue that RIS is not part of the spectrum of MS, but we'll see what the formal diagnostic criteria have to do with that. And just as a side issue, there was one of the questions in the pre-submitted questions had to do with misdiagnosis. I'm going to try and run down to that now and just answer that while we're talking about it. And this question was, do you believe that some folks have been misdiagnosed with MS when in fact they actually have Lyme disease? That's a not uncommon question that comes up. In Colorado, of course, we don't have Lyme disease because the tick that carries the bacterium, the Borrelia burgdorferi, it can't live in Colorado. It's too dry here. So we do not have that tick-borne disease here in Colorado. But of course, someone could get tick-borne illness elsewhere and come back to Colorado. So we do sometimes see Lyme disease, but it's much, much, much less common, say, than in Minnesota, or the East Coast. Lyme disease actually comes from Lyme, Connecticut. And so Lyme disease is pretty common there in New York, out on Long Island and elsewhere, but extremely uncommon here. The most common misdiagnoses are people who've gotten scans for other reasons and have little white dots on their brain scan, typically with either what we call microvascular disease, such as the typical things that cause vascular disease, such as diabetes, high blood pressure, high cholesterol, smoking. They have those as risk factors, and they have essentially very small and presumably asymptomatic strokes that are seen when they have those non-specific little white dots on their brain scan. Another major cause is migraine. In younger people, it's typically migraine when they're non-specific and someone has a headache. And in older individuals, it's more typically microvascular disease. In addition, in my own study that I published many years ago, looking at, I think, 281 people that came to us for a question of, do I have MS? Only about a third actually had MS. About a third had other clinical syndromes that were neuropathies and other things. But up to about 20% of people actually had somatization disorder, a psychiatric diagnosis as well, as the major cause for their symptoms. So we have to always remember there are multiple different causes of symptoms that might crosstalk or crosswalk with MS. But in this state, at least if you were thinking that you got bit by a tick here, the likelihood of being Lyme here is extremely low. So that has to do with some diagnostic issues. On the therapeutic front, many of you have heard us talk in the past year or two about a new potential category of medications that would be hopefully useful for MS in both relapsing younger patients as well as progressive older patients. And this category of drugs is called BTK inhibitors. Like many of the drugs that we presently use, we're sort of borrowing this from oncology. And this is a class of drugs that are enzyme inhibitors, and that the BTK is Bruton's tyrosine kinase, which is a kinase enzyme inhibitor. And kinases are molecules that move a phosphate group from one molecule to another molecule. It does not sound like much, but that is a trigger inside cells that tells cells to either turn on, turn off, to emit some products outside of it, to interact with other cells, or do a variety of other things. Kinases are used all over the body as signaling cells, signaling portions of cells. And so they're very important in general, but they are also typically cell specific. So some might be appropriate in this organ or that organ, or in this one white blood cell versus a different white blood cell. So the Bruton's tyrosine kinase inhibitors would be affecting kinases in B lymphocytes, the same cells that we remove with all of the present drugs that we use, like rituximab, ocrelizumab, Briumvi, and Kesimpta. But as opposed to removing the cells, they just sort of turn the volume down on the inflammatory component related to that. Now that's interesting, and that would have a similar effect potentially to the drugs I just mentioned, but it also may affect so-called microglia. Microglia are white blood cells that live inside the brain and the spine. They don't circulate all over your body. And these are potentially pro-inflammatory, even anti-inflammatory cells that can exist in multiple different states. And Bruton's tyrosine kinase inhibitors may have an impact on turning down what's going on with them as well, make them less inflammatory. And why do we care about that? Because progressive MS appears to be more dominated by those cells that are already inside the nervous system, so-called compartmentalized inflammation, especially as related to microglia. And so if it turns out that that is true, that could become perhaps a very effective medication for treating progressive MS, which would be very useful. And there's multiple different drugs in this category of drugs that are being studied right now in both relapsing and progressive MS. And in December, the very first study came out that was looking at relapsing MS and comparing a drug called evobrutinib to Aubagio, one of our typical oral medications that's used for multiple sclerosis, especially relapsing MS. So in a relapsing study in younger patients, when you did the comparison, unfortunately, this drug was no better than Aubagio. And so both of them work, but this drug was no better than Aubagio, and this would be presumably want to be marketed by the pharmaceutical company that was making this drug as a very expensive drug, yet the generic drug for Aubagio costs $17 a month at Mark Cuban Cost Plus. So trying to compare an $80,000 a year drug to a $17 a month drug was too much for the company, and they abandoned the drug based on its failure to be better than Aubagio. Now, there are still multiple studies that are ongoing. There are reasons to believe that they made some mistakes in how they did this particular study that I mentioned. But we're really most interested in the progressive MS studies anyway. I mean, we realistically don't need a better mousetrap for dealing with relapsing MS. What we really need is treatments for older patients with progressive MS. So we're very interested to see if that works out. One other treatment issue for a new potential medicine, you may have heard about this one, is called Frexalimab. Frexalimab is again another monoclonal antibody. That's the MAB part of the drug. And this is directed against something called CD40 ligand. That is CD40, just like CD20, the protein on the outside of white blood cells, is a different protein on the outside of white blood cells, and it's a co-stimulatory molecule. That is, the CD40 on one cell has to dock with the ligand on another cell. They dock, and this is a co-stimulatory molecule which makes the cells get all revved up. And then, as it's been seen, this could be a good way to block the development of inflammatory lymphocytes, white blood cells. And in fact, we've been working with a gentleman here, a PhD in the Webb Waring Institute, Dave Wagner, for many years, looking at CD40 representation on the outside of white blood cells. And he got the idea originally to check in MS patients because he discovered that there's an overproduction of this CD40 protein on the surface of white blood cells in diabetic patients, in type 1 diabetics. And that's an autoimmune condition that actually has many immunological components similar to MS. And so he said, well, hey, why don't we check on MS to see if it's overrepresented in MS as well? And we showed in a paper we published 8 or 9 years ago that in fact it is overrepresented. And it's overrepresented in relapsing patients, primary progressive, secondary progressive patients, patients newly diagnosed, patients diagnosed 30 years ago. And so there's clearly something about this molecule because, in fact, in people who do not have MS or other autoimmune conditions, it is not elevated. So it's now interesting to see, 8 years after we were the first to show elevation of CD40 in MS patients, there's now a treatment trial in phase 2 trials that looks quite promising. And phase 3 trials are coming up to block this molecule from stimulating white blood cells to get very activated. So those are just a few sort of interesting little tidbits from recent studies that are ongoing. And there remain a number of other studies looking at products that may help protect cells from dying, so-called neuroprotective molecules. There's nothing new on the remyelination front. That is the ability to potentially rewrap the axon, the cable that connects one nerve to another. That cable is typically covered with myelin, which helps the electricity conduct more rapidly. So far, most of the studies have been relatively not helpful. One study, though, with Clemastine at least showed some potential changes that could be measured electrically and how fast the impulse moves, so-called visual evoked potential moves from where it comes into your eye at the front, and how long it takes to get to the back of your brain where there's visual processing that takes place. Also in the same group, same study, they showed that there might be some changes you can see with remyelination on MRI scan. So at least as a proof of principle, Clemastine may be able to show some very modest changes that we can measure either electrically or on MRI. But functionally in the study, there was no improvement in vision, which is what we really care about. This was an optic nerve study that as people had prior optic nerve damage were treated with placebo, and there was really no difference in the clinical outcomes, unfortunately. And that's what we ultimately care about. It's nice to show a proof of principle that you can measure some things that are slightly different, but if there's no improvement in vision in that model, it's unfortunately mostly considered a negative study. But there's also studies ongoing looking at regeneration, that is, in potentially growing nervous system tissue in the brain and spine. These are very early studies, but as opposed to stem cells of the bone marrow lineage, which would sort of reboot the immune system, which is being done quite frequently now, and ongoing studies are also being done with those. This would be using stem cells that are really neurological precursor cells. They've gone down a different lineage. They could never become bone marrow cells. They can never become skin cells or hair cells or liver cells. These would only be able to become nervous system cells, and you can generate these and then potentially put them in the spinal fluid, either with a spinal tap in the lower back or actually with a port on top of the head, where you'd be able to inject them down into the middle of the brain where the ventricles are. The ventricles are where the spinal fluid is made. And those injections then, presumably the cells would disperse. They would float all over where the spinal fluid goes. They would attach to the brain and the spine. They would travel through the different tissues, and then they would potentially set up shop and either fully differentiate and become nervous system tissue, or more likely, they would stimulate the cells that are already present in the brain and the spine to then, excuse me, fully differentiate and actually set up shop and make nervous system connections just like the brain would during development. So these are studies that are very early, phase 1, phase 2 studies, but this is incredible to even consider that we can talk about that, since when I was in training, that would have been considered crazy talk. And so now this is really interesting. It's beyond science fiction. We're now in the science mode. Excuse me. There are a number of questions that popped in. I just want to see if any of them are relevant to what's going on. Let's see. So as the question came from David, is it true that one of the 3 BTK drugs clinical trials failed? That's correct. I just mentioned that. A notice from Kelsey that put up, you can learn more about some of these studies that I just mentioned in Dr. Wolf's previous study with our education summit that was done in the fall. Excuse me, in the spring. It's not the fall yet of 2024. So now I'm going to go to some of the different questions, and I'll be looking to my right periodically because that's where I have the questions on my other screen. The first question is, what are the highest efficacy drugs? And the question really revolves around, are all the drugs the same, the disease-modifying therapies? Are they all the same? And when I say DMTs, what I'm talking about is disease-modifying therapies. That's the term we use for the MS medications. They're not all the same, obviously. Some are different by the way they're delivered. Some are different by the different types of side effects or risks. Some are different by efficacy. Some of them are different by impact on pregnancy. Some of them are different, perhaps in different age groups. Some of them are different by how insurance covers them. But what we care about the most is how well do they work and what are the risks associated with them. And so we can categorize the different medications into roughly 3 categories, sort of low, medium, and high in terms of efficacy, how well they work. And so at the bottom end would be the older injectable drugs like Copaxone and all the interferons, as well as Aubagio. They work fine, but they're modestly effective. In the middle would be probably the fumarates like Tecfidera, Vumerity, and Bifirtam. Probably Gilenya and the drugs like Gilenya, which is Gilenya, Mayzent, Zeposia, and Ponvory. And then slightly above that would probably be Cladribine, one of the other oral medications. That's the only drug in that class. But the highest efficacy, that is showing the biggest impact on reducing relapses, reducing new scan changes, and reducing progression of disability, with most of these impacts having the greatest effect when people are younger, are the following. Drugs we don't really use much, such as mitoxantrone, one of the older drugs for MS, was approved over 20 years ago, but it has a very poor risk profile, and again was a drug borrowed from oncology. You can only use it for a couple of years, and then the risks accumulate over time with regard to heart failure and delayed leukemia. And so this drug was mostly abandoned. I'm not even sure it's still approved for MS, but it was highly effective, just the danger was not reasonable. Another drug that's really used almost not at all in the United States or around the rest of the world at this point, it's well under 1% of the total market, is Lemtrada. Lemtrada or alemtuzumab is a highly effective medicine, again, for MS, but unfortunately has a very significant risk profile. Up to 40% of people develop other autoimmune conditions, especially in the thyroid, but other ones in the kidney and also in against platelets. Infections are serious, potential malignancy is an issue. And more recently, in the last couple of years, there's been evidence that you can have hemorrhagic stroke or bleeding strokes. So that profile is not reasonable when we have a number of other drugs that have better risk profiles. So of the ones that we use more commonly, the two classes are Tysabri or natalizumab, which is the only drug in this class until just now. We have a second drug in this class called Tyruko, which is a biosimilar. I'll come back to that in a minute because I think it's important to know what a biosimilar is. But then also the class of drugs that are commonly used, including rituximab, Ocrevus, Kesimpta, and Briumvi, the so-called anti-CD20 drugs, 3 of which are infusions every 6 or longer number of months between infusions. And Kesimpta is a every 4 weeks injection into your leg subcutaneously. Those are the most highly effective drugs that we have. And I'd like to talk a little bit about Tyruko. So for those of you who are unfamiliar with a biosimilar, it's sort of in the same family as a generic, but there are important differences. So when a patent runs out on drug A, maybe it lowers your cholesterol. It's a chemical, it lowers your cholesterol. The patent runs out, a generic drug maker or any drug maker can make a knockoff, essentially. It's the same chemical. It has to be chemically equivalent, according to the FDA rules, in order to get approved. And if they can show that it's chemically equivalent and that they can make the drug on a routine basis and safely, and all the production qualities is good, then the FDA will approve it and they can sell it because the patent has run out. That is a generic. They have the generic name. They don't have their own name. They don't have their own package insert. They tie on to the package insert with all the different side effects and everything from the original drug that it's copying. And most importantly, they are not required to do any tests that lowers your cholesterol or lowers your blood pressure, or whatever it's supposed to do. So there's no studies proving that it does anything in your system other than it's chemically equivalent to the original drug. A biosimilar is different. A chemical is this big, a biosimilar is this big. These are large molecules. Importantly, though, they're made inside living cells. That's why they're called biological drugs. Typically in mammalian cells like Chinese hamster ovary cells, or even potentially sometimes human cells. And the way you make these, and these are all these monoclonal antibodies, natalizumab, ocrelizumab, rituximab, etc., is that you take the DNA that will actually become the RNA, which then becomes the protein, which is the dictum of molecular biology. You take the DNA that makes the protein and you put it inside cells. It's called transfection. You put them inside the cells, and then the cells reproduce. And as they reproduce, they make a lot of proteins, not just the protein you're interested in, but a lot of proteins. Then you stop the process, you crack open the cells, you get rid of the proteins and other cell products that you don't want. You typically run it over a column and you have a way of catching or grabbing the protein that you want, you wash everything else off, then you wash off the drug that you do want, you catch it, you purify it, and that's the drug. So when that patent runs out, it can also then, it's fair game for somebody else to make it. It's just a much more complicated process. But importantly, when you do all that reproducing and whatnot, you may have slight differences because of mutations that occur in the cells. So maybe the protein that you're making is slightly larger or smaller, or maybe it slightly folds differently. And that means it may interact with the receptor typically that you're trying to interact with slightly differently. Now, this is true, let's say in the case of Tysabri, it's true every time you make Tysabri also, but it is also true when you make a knockoff of it. So it may not be exactly identical, but it's chemically very similar. But more importantly, the FDA requires that you actually do a non-inferiority trial showing that that drug, the new one, the knockoff, the biosimilar, is non-inferior in the condition which you want to get the label for. You want to get the drug approval for a specific condition. And so you have to do a non-inferiority study. So the non-inferior is just, inferiority just means it's the statistical analysis that you do, as opposed to proving that it's better or that it's equal. You just show it's not inferior. And so that's just the way you do it statistically. But you have to do that. And then you get your own name, you get your own label, you get your own package insert, you get your own set of side effects, and then you can market the drug. So Tyruko is in fact a biosimilar for Tysabri, which was approved by the FDA late last year, and it's waiting to be marketed. Allegedly, they are going to market it in the next 12 days. That is by the end of the second quarter of 2024. Well, that's the end of June, which is 12 days from now. The reality of that is zero. It will not be marketed in the next 12 days for at least three reasons. One, as soon as the drug was approved by the FDA, Biogen filed 28 patent objections against the drug, saying, yes, that patent ran out, but we have 28 others that they are saying are still covering Biogen, the Biogen product, Tysabri. Now, this is a common ploy that all the major large pharmaceutical companies do to try and keep other drugs off the market. So there's nothing new there. This is a common thing that they do, and they try and essentially tie people up in court or scare them off from using the drug, even after it's approved by the FDA. So the question is, will they market the drug before they have all those patent objections clarified in the courts, or will they wait until they're clarified in the courts, which will be expensive and which will take time? That remains to be seen. I don't know because I don't work for the company that makes it, which is Sandoz, which used to be owned by Novartis. A second objection, or a second problem really, is that the FDA said, well, that's great, you're approved, but where's your JC virus test? Many of you know that the only major risk with Tysabri is that if you have been exposed to the JC virus and you take Tysabri, you are immunosuppressed in a very unique way, and it is possible that you can get this brain infection from the JC virus. And the clinical syndrome is called PML, or progressive multifocal leukoencephalopathy. It's a very horrible brain infection and encephalitis that can be fatal in up to 25% or more of people that have this. This is when you've been exposed to the virus, it's sitting in your body, but somehow when you're on Tysabri and some of the other drugs we use, the drug can be released from your kidney or your bone marrow, mutate, go up to your brain, and cause this horrible brain infection. It happens very rarely, but it can happen. And so Tysabri, Biogen makes Tysabri. Biogen has their own test. And when someone right now gets a JC virus test done, Biogen's doing that test, I believe, still for free. And so the FDA said, well, Tyruko, you guys can market that, but you have to have your own test. And so they didn't have a test. So they have to develop a test. And they're not going to be able to sell it until then. The third issue is that until you're on formularies of insurance companies, it's going to be very hard to market the drug. Every time, if it's not on a formulary, if the insurance company has said, yes, we understand, we recognize this, we'll pay for it, then every time you request that from that insurance company, it's going to be like you're reinventing the wheel every single time. And that's going to markedly inhibit physicians and their offices from writing for the Tyruko, because it's going to be a painful regulatory process just to get it paid for by the insurance. So they would rather wait until it's on the formularies, and then you can just simply order it. But it will be cheaper. It's usually about 70% of the price of the other drug. A regular generic's usually about 30% of the price because they're much simpler to make. This is a much more complicated molecule. So for those of you on Tysabri or have friends on Tysabri, we'll see when this drug becomes available, but I highly doubt it's going to be in the next 12 days, even though they insist when I've talked to their representatives that they're going to do it. So we'll see. I'd love to be wrong. We always like to have more choices, and it will be cheaper. One downside when a generic or a biosimilar comes on the market is that it is often the case that the price of the drug goes down. That's a good thing. We like that. The problem is many of our patients receive copay and deductible assistance from the companies. And if the price goes down, the first thing that those drug companies do is they take away the copay and deductible assistance. So while it'll be cheaper for the insurance companies, it is often more expensive for the patients when generics or biosimilars come out because they lose that copay and deductible assistance. So we'll see what happens here. Right now, we don't have an answer, and I'd be interested to see what happens with the marketing of this drug, but it's not going to be in the next 12 days. You heard it here first. There is a question related to Kesimpta. I'll just mention it's in the box right now. Is Kesimpta every 4 weeks? It is every 4 weeks. It doesn't matter when you do it. You can do it at 3 o'clock in the morning on a Tuesday if you like. It can occasionally be 5 weeks if you're a little late. It's not a big deal. It's not that rigid. You can use it, but essentially it's indicated at every 4 weeks. And there's a question about the sub-Q injection process. It is with the FDA for approval, anticipated approval timeframe, how long will be? I'm not sure what that person is talking about. That's from Tom. Tom, if you have some, you didn't mention what drug you're talking about. You could be talking about, there's one with Copaxone, there is a depot version that is under development that would be into the muscle, I believe. It's presently subcutaneous. And that would mean that Copaxone could be used once per month, which would be an interesting issue. Copaxone is not one of our more efficacious drugs, but it should be approved. We're happy that it's approved. And if you only had to take it once a month, that would be highly convenient for people because it's very, very safe. And that would make it not only safe, but very convenient as well. So if that's what you're talking about, Tom, perhaps that's what the answer was. So there were numerous questions. I'm just checking my time here. Got about an hour left. There were numerous of the pre-submitted questions revolving around aging issues with multiple sclerosis. And many of you may know, especially those of you who may see me as a patient, that I've been very interested in aging issues, perhaps as I've been aging, and specifically interested in the questions revolving around the use of the disease-modifying therapies as people age. So I'll give maybe 3-4 minutes of background and then try and go through the questions, and they'll just sort of flow normally from the discussion. And so with aging, several things happen pathologically, clinically, radiologically, that are different at different phases of someone's time and their age with regard to multiple sclerosis. And this is true with other chronic autoimmune conditions, not all, but it's certainly true with neurological ones, how things may change over time. And when people are younger, and so the typical patient has run-of-the-mill relapsing MS diagnosed between about ages 25 to 40 or so, and they have maybe an acute optic neuritis, maybe a spinal cord inflammatory syndrome with numbness and tingling from the chest down or whatever it may be. And they have relapses followed by remissions, relapses followed by remissions. We can reduce those with the medications, the DMTs that are presently available. But as people get older, the likelihood of having new relapses diminishes. And so they just become less and less common. So it's partly age-related and partly related to the time of onset. So your highest risk of having a new relapse is when you're newly diagnosed. And then subsequently, there's a downturn, slow reduction over time, so that by the time, if you're diagnosed when you're 30, by the time you're 60, your risk of having a relapse in any 1 year is probably well under 5% on average, if that's when you were diagnosed. In addition, if you look at age, the peak period of time is probably between about 25 and 35 or 40 or so. That's the peak time for having a relapse. And then that also goes down over time, mirroring the age of onset or time from age of onset as well. And you see the exact same thing with new active MRI scan lesions as well. And as many of you know, sometimes people just sort of stabilize and they don't have any more relapses. And, you know, they may break their leg or need a new kidney or any of a variety of other medical conditions, but their MS is pretty stable. While others may go into a phase where they have slow worsening over time that we refer to as secondary progressive MS. That is, at first they have relapses, those diminish over time and seem to be almost replaced by this slow worsening. And then finally, some people, and we call that secondary progressive MS. But then finally, there are some people, maybe 10% or so of people, who never have a relapse, or if they do, it's long after they start with slow progression. They don't have a preceding set of relapses, just have slow worsening over time, typically starting around the same time that secondary progressive MS starts, which is roughly 40 to 45 on average for most people. And so these are all different phases clinically and radiographically, but more importantly, perhaps with regard to how the drugs work that are presently available as DMTs, the pathology changes as well. When people are younger with relapsing MS, most of the immunological problems that are changing, causing all these issues that we think of as the autoimmune attack against the nervous system, most of those are taking place in the blood or in the lymph nodes. That's in the periphery, not in your nervous system like your brain. They're going on there, but then these cells enter the brain and the spine and cause the problems and transform over time. So we think of that as these lymphocytes, white blood cells, rushing into the nervous system, causing acute attacks. The lesions that we see pathologically wrapped around veins that we see on the MRI scans as the white dots, they're next to, you know, deep in the middle of the brain, especially, that we call Dawson's fingers. They look like almost flame-shaped and going out from the middle out towards the outside of the brain. And that's what we think is the classic MS relapse-associated MRI scan and pathological changes. But in reality, there's also going on from the very beginning. These microglia that I mentioned before are also very active inside the nervous system with so-called compartmentalized inflammation that is of a very different type. And this type is different. It doesn't respond to the medications that we presently have, whereas the cells rushing into the nervous system that I described first with relapsing MS, all of the medicines we have affect that very well and turn that down. They don't work on the microglia. And as people age, as they have less and less of these relapses and less of the kinds of changes that cause the pathological changes, MRI scan changes we see, those become less prominent, and the microglial aspect, the compartmentalized inflammation, becomes more prominent, especially with progressive MS patients. And so that's what's going on clinically and radiographically and pathologically over time as people age. And those are differences. Those change, and the medications that are presently available as DMTs simply do not work as well, if at all, but certainly not as well as people age and as people have these pathological changes that are ongoing. So that's why we need drugs, perhaps like the BTK inhibitors, if in fact they work, because they will have an impact on those microglia and related processes, which are so prominent as people age. In addition, we know several things are true. The medicines, as I mentioned, have been demonstrated to have the greatest impact when people are newly diagnosed and younger. There's almost no data over the age of 55 with these drugs, because most of the time people over the age of 55 have been excluded from the studies. The studies showing the best benefit are all in the relapsing MS studies, and there's only modest benefit, if any, shown with the progressive MS studies. Only one drug, Ocrevus, is approved for primary progressive MS, while all of the drugs are approved for so-called active secondary progressive MS. What that really means is that you can have slow progression when you're 45, but the evidence shows that you have to have had a recent relapse or a recent active lesion on your scan, your MRI scan. Otherwise, the medicines really don't work very well. And they show this in drug after drug after drug after drug. And they show that also with progressive MS. Even Ocrevus or rituximab, which is not approved for primary progressive MS, but looks very similar to Ocrevus because the molecules are so similar to one another. They both show that the people that benefit the most are younger and have active disease on their MRI scans, just like it is with the relapsing MS studies. So the reality is that the presently available disease-modifying therapies have their greatest impact, if not exclusive, certainly the greatest impact in younger patients with relapsing MS, or if they have progressive MS, if they are younger and have active disease on their scans, or even had a recent relapse with secondary progressive MS. So the two together, if you will. So that raises the question, well, okay, well, if these drugs are not demonstrated to show benefit, and we know that some of them will have perhaps significant increased risk, especially regarding mostly with infection, perhaps with even related malignancies as people age, at some point, does it make sense to consider just not using the medications? Would you either change to a medication that perhaps has lower risk, even if the benefit is not as great, and or would you discontinue medications? So in the case of somebody who is stable with their relapsing MS and they are older, over the age of 55 or 60, would you consider a trial either de-escalating to a less risky medicine and or stopping medication? And similarly, if you have progressive MS and you're not deriving any benefit from it, and all you have is a lot of risk with modest, if any, benefit, would you change to nothing, discontinue, are the questions that arise. And so, so with that, the questions relate to, would you de-escalate over time potentially to a less risky choice, especially if you are stable for a prolonged period of time? And there are now studies that are ongoing looking at, for example, taking Tysabri and not treating it every 4 weeks, but using it every 6 weeks. With Ocrevus, rituximab, or Briumvi, not using it every 6 months, but using it every 12 months. With rituximab and or ocrelizumab, but especially rituximab, 15 years ago when we started using rituximab, we used 2,000 milligrams every 6 months. Now we've whittled that down to 500 milligrams every 6 months. So we've already done de-escalation with rituximab over the years. So would you potentially de-escalate drug to try to remove risk? And this is especially important, for example, with the CD20 drugs like Ocrevus, rituximab, Briumvi, and Kesimpta, because the longer that you use those drugs, the more you have a risk of infection because you're getting older, but also the normal antibodies that your body makes, they go down over time with that class of drugs because you're removing the cells that ultimately become the cells, plasma cells, that make antibodies. So if you can't replace them because you've been removing those cells, you're not going to have as many antibodies, and then you're going to have more risk of infection. So can we stretch the use of those drugs out, especially the IV drugs, not so much for Kesimpta probably, but for the other 3 that are IV drugs, can you stretch out their use to every, say, 12 months, 9 months, 12 months, even longer, and then you have not repetitively removed the cells that are going to become the plasma cells that then make the antibodies? And the answer seems to be yes so far, especially for patients who are middle to older age, even younger patients too, if they've been on the drug for a while, 3, 4, 6 doses, it's every 6 months. There is data that suggests that you could extend the dosing out and not have an increased risk of relapse, but on the other hand, you get some benefit. Number one, you get the long-term benefit I mentioned with less infections, but you definitely have short-term benefit, multiple studies show, with less infections. And in addition, because you can stretch out the dosing, you can actually take, for example, a COVID vaccination or a flu vaccination or a Shingrix vaccination, and you can take it at a time that you're pretty far from your last infusion, and then you can get a better vaccine response as well. So stretching the dosing interval out can potentially, with this class of drugs, with the CD20 drugs like rituximab, Ocrevus, Briumvi, Kesimpta, well, actually not Kesimpta because we're not going to stretch out at every 4 weeks injection. At least there's no data on that yet. You can stretch that out, and then you could have multiple potential benefits short-term and long-term. It's also just more convenient for the patient. They do one infusion a year, for example, if it's every 12-month dosing. So those are de-escalation approaches, which could be used for people, especially who are stable and who are older. Another de-escalation approach is you could, as opposed to, say, the risks with, say, that class of drugs, the CD20 drugs, maybe you could reduce that risk by going to, say, one of the fumarates like Vumerity, or maybe even one of the drugs in the Gilenya class, either Gilenya or it's generic likely, or maybe Zeposia or something. That is, you could go to a drug that had less risk and wouldn't have that impact on the production of antibodies. And so that would be one way that you could also de-escalate for someone who is stable. But the ultimate de-escalation is discontinuation. And so there is now data, as many of you know, from the study that I and 19 other centers in the United States did, the DISCO-MS study, and from our also from our extension of that, which is not yet published, but which we've reported in a couple of meetings, that show that when you take someone who is stable, either with relapsing or progressive MS, but stable by meaning not having a relapse for at least 5 years and not having a new scan change for at least 3 years, and they've been on drug the whole time. When you take people off when they're over the age of 55, the likelihood of having new disease activity is pretty small in the discontinuers, and not terribly different from those who continue on their drug. It's just a randomized controlled trial, half on, half off drug. And in our study, the average age was 63, and the average time since last relapse was 14 years. So these are quite stable patients. But when you look at those patients, there's very little difference between them. However, there's probably a small increased risk, about a 3% chance per year, greater than those who stay on drug, of having 1 or 2 new dots on your brain scan, which were not associated with relapse, not associated with a change on examination, and not associated with differences in cognitive tests, not associated with symptom scores or anything like that. So discontinuation in that context looks reasonably safe for many people, but with a slight potential risk of having a new dot or 2 on your brain scan of unclear long-term significance. In the 40 months of the study that we have with our extension, does not appear to be associated with a bad outcome, but we don't know if that means the same at 5 years or 10 years. What about people with progressive MS? For people with progressive MS, as I mentioned, we have very little data to show that they work really at all, but those who benefit the greatest are those with recent relapses and or active lesions on their scans. But for many people, they'll have started on a drug 15 or 20 years ago. They will maybe changed a few times. They go into a progressive phase. They're on medication X, whatever it may be, and yet they continue to slowly worsen. And then the question is, what do you do? Sometimes if they're on a medication that is clearly inferior, let's say Copaxone or something, then maybe escalating to a more effective drug, especially if the patient is still relatively younger and or has recent disease on their MRI scan, or even has had a recent relapse on top of their slow progression, then maybe going to a more highly effective drug makes sense. But let's say someone's, for argument's sake, 60 years old, 65 years old. They've had progressive MS for 10 to 15 years. They haven't had a relapse in 15 years. Their scan hasn't changed, which is the norm. And it's an oddity. We don't understand it, but the patient continues to slowly worsen, yet the scans don't change as people age, is the norm. So maybe they've really been stable from the scan point of view for a long time, stable from the relapse point of view for a long time, yet slowly worsening for 15 or even longer number of years. There's really no evidence that the medicines that we have presently available have any impact. And so you would consider discontinuing the drug because you're really just accumulating risk, but with really no benefit to show for that. And so how you view that and how you go forward with that is very individual. Some people would still prefer to stay on a medication because they feel uncomfortable not treating their MS, even if the evidence supporting their use is very small, if not non-existent. And I understand that because we don't have an alternative. That's why we're so interested in any new category of medication such as the BTK drugs, that may have an impact on progression, because that is the greatest unmet need. So there's a huge amount of effort with the Progressive MS Alliance, that is all of different MS societies around the world getting together, funding progressive MS research in a number of venues, a number of types, neuroprotective, remyelinating, regenerating, all sorts of different approaches, all being looked at because that is the greatest unmet need. So as people age, as they get older, if they have progressive MS, it's going to be a very individualized response as to how they deal with either staying on drug or going off. And so when I have discussion with patients, I just explain what is going on. I ask their opinion. What do they think is most important for them? And then if they do a trial off of medication, then what we do is we say, okay, well, just think about how your MS has been progressing while you're on medication. And then we'll do it, go a period of time off medication, and we'll see how you do then. And if you think that your rate of progression has increased, we can just go back on the medication. I would say in the vast majority of cases, that is not the case. So if I mentioned like the 65-year-old hasn't had a relapse in 15 or 20 years, and hasn't had a scan change for that period of time, yet they've been slowly worsening while on medication. The vast majority of the time, unfortunately, when we take them off medications, they just simply progress at the same rate. They don't typically accelerate. They don't decelerate. It's just about at the same rate. For the individuals who are stable over time, that is, are not having relapses, are not having new scan changes, and they go off their medication, we continue to monitor them. We monitor them for relapses. We monitor them for scan changes, be they either coming off as someone who we call relapsing MS or coming off drug who we've called progressive MS. We monitor them sometimes even more than they were on drug, because we're trying to make sure we don't miss an opportunity to restart medication if their treatment discontinuation trial seems ineffective. I would say we would like to have better markers that would tell us whether or not there is safety in potentially going off medication in that context. So there's a lot of interest in biomarkers, serum neurofilament light, which is a protein that's inside the axon, the cable of the nerve. Then when you damage that, it leaks that out. You can measure it in the spinal fluid or in the blood. Or GFAP, which is an astrocyte marker. Astrocytes are the most common cell inside the nervous system. They're supportive cells that do many, many different things. And if you have damage to the astrocytes, then you can also see elevations of this GFAP molecule. And there are a bunch of other markers that if someone goes off medication, if those markers go up, then that would be a very early sign that maybe you should go back on the medication. So far, the biomarkers have not been useful in this context, and they really haven't been useful in any context on an individual basis. We know that the markers are useful in populations if you want to say maybe this drug is better than that drug, because we know that when you start this drug, there's a serious drop in the neurofilament light compared to the other drug. It's useful in that context, but using it in the office with a single person saying, we're going to monitor every 3 months or every 6 months or every 12 months your neurofilament light, and then make treatment decisions based on that, has not been useful. There is a product out there called MSDA, the multiple sclerosis MSD, the MS drug disease activity scale. It's an 18 biomarker panel put together by one of the companies that does this biomarker research. And they feel that this is more predictive of disease activity, either when you're on drug or when you're starting drug, or just, when you're newly diagnosed, or potentially, although they don't have data yet, when you go off medication. But what they've not been able to show, and what none of these biomarkers have been able to show, is that if you are checking at time X and there's a bump up in your serum neurofilament light or one of these multiple biomarkers, one like the MSDA or others, that predicts something that happens later. Oftentimes, what you see is that there's an increase in whatever marker you're looking at, and it's around the same time as maybe a relapse or an active lesion on your scan, but it doesn't precede it. It's just sort of around the same time. And there's one study that was just published 2 weeks ago from an old study with Tysabri, where people were stopped from their medication. And then they said, well, what happened to the neurofilament light? Well, only about a third of the time did it go up enough that they could say that, yeah, that's a serious increase. And that was related to seeing new activity on the MRI scan. But it occurred about 8 to 12 weeks after the scan changed. So it didn't predict the scan change, it succeeded the scan change. So that's not a very good marker. That's not a way to save an MRI scan. We already saw it on the MRI scan before there was a change in the blood. So we need something that's useful ahead of time on an individual basis to predict changes that are going to happen clinically for discontinuation, but also potentially for switching medications. And so we'd like to be able to have a marker that is cheap, is dynamic, is predictive, and is reliable, that would predict changes should we change medications or go off medications or whatever we do. And presently, we just don't have those. So to get to the questions that are more specific, so what would you do if you were a 65-year-old who hadn't had a relapse in 20 years and hadn't had a scan change for 20 years, and you had progressive MS, and you're on a medication that is considered a reasonable medication for your MS? One of the considerations is to go off, but that's going to be an individual decision. When you make a decision to go off medication in whatever context, or even de-escalate a medication in any context, it's important to remember that you're still going to want to monitor. It's extremely important. We don't just say, hey, good luck, you went off your medication, call us if you need us. We actively monitor you. And that's seeing you, examining you, checking you for relapses, and checking scans over time. Again, sometimes more than when you were on the medication. And so let me see, I think that answered most of the medication issues around aging. So the important points are there's going to be an individual decision. We're all different. We don't have any specific algorithm that says this number of years since onset, this number of years without a relapse or a scan change. But the general idea from a meta-analysis, that's when you take multiple studies and put them all into one pile and look at all of them and look at the things that they looked at similarly, and then try and do a statistical analysis to say, if you go off drug, what happens? What are the risk factors associated with recurrence of disease activity? And this has been done by a group in Italy. The gentleman who's the lead author is Prosperini, who's a prominent researcher in Italy. And they looked at a meta-analysis. And what they concluded from all of these studies, and this was before our DISCO study was completed, so it was just the observational, non-randomized controlled trials, was that after about age 60, or after 10 years on any of the drugs, or with 8 years or longer since last relapse activity, that the risk of a relapse is probably less than 1% over the age of 60, 8 years without a relapse, or 10 years on drug. That's not a hard and fast rule, but the risk is probably low in that context. But some combination of no relapse, no new scan change, longer time since disease onset, and older age is going to give you a greater likelihood of having no recurrence of disease activity should you de-escalate or do the ultimate de-escalation and discontinue. So that's something that you have as an individual discussion with your doctor and see what makes sense. And so one question specifically is the current conclusion about disco MS. If you had one punchline to say, and this person used the term DMARDs in their question. We don't use that term. That's a disease-modifying anti-rheumatic drugs. So we use disease-modifying therapies, not DMARDs. The DMARDs are for rheumatologists. And that includes a variety of different drugs, mostly that we don't use. But the main takeaway is that in the population that we looked at, and using the medications that we looked at, so stable patients, average age of 63, average time since last relapse of 14 years, and mostly using older injectable drugs or Tecfidera or Aubagio. Over 90% using those drugs, only less than 10% using the more highly effective drugs. There might be a small increased risk going off medication in that context compared to staying on medication, a small increased risk of having a dot or two on your brain scan over a 2-year period of time. And then with the extension out to 40 months. There has been a study published March 25th this year, an observational study, not a randomized controlled trial, that looked at more highly effective drugs when people went off of Gilenya, or if they went off Tysabri, or if they went off rituximab or ocrelizumab. And they looked at all 3 classes, so rituximab and ocrelizumab combined. And they looked at the classes all combined. And they did what was known as a propensity match study. They looked in all of France in their what's called the OFSEP database. And in this database, they said, okay, let's find all the people that were on these drugs that were over the age of 50, had been stable for at least 2 years with regard to having no relapse or no scan change, and see the ones that either discontinued medication or stayed on their medication, and then follow them in this database for 2 years. Actually, it was even out to 5 years, but the data was good out to 2 years because then the numbers just dropped off. And said, okay, well, what's the risk of having a new relapse or having a change in disability on what we call the EDSS, which is a disability score from 0 to 10, high being a worse score. And just ask the question, when you propensity match, that is, you match them up by age, by sex, by disease duration, by when you last had a relapse, et cetera, as best you can, what happened to the people that stayed on drug compared to the people who went off drug, and looking at specifically the more highly effective drugs, because not only did DISCO-MS use mostly drugs that were of the lower effectiveness, because that's the people who were stable for a prolonged period of time, but there's also a study from the Netherlands called the DOT-MS, another randomized controlled trial that also only looked at the older injectable drugs, as well as a couple of the oral drugs, Aubagio and Tecfidera. So this is the first study that really exclusively looked at this, but it's an observational trial, not a randomized controlled trial. And so what did they see? So who is in the study, first of all? So the average age in that study was not 63 like DISCO, but was actually about 57. In addition, the average time since the last relapse was much shorter than the 14 years in DISCO. It was more like in the 4.5-year range. In addition, these patients, in order to get the better drugs in France, they have to fail multiple other drugs first. That's just the way the national health system works. So over 35% of them had failed 3 or more drugs, 3, 4, 5, or even more drugs, but at least 3 drugs. And they also had a higher disability level. They had much more disease disability on their average score, about 1.5 points higher on this 10-point scale. So these were not the same patients as in DISCO. We had much more stable patients than they did. But what they showed was when you discontinued those medications with not as stable patients as ours, they showed that going off medications was not good. The average age being 57, not 63. But also more importantly, much more recent disease activity. And so the drugs that did the worst were actually Gilenya and Tysabri, which are known to have a sort of a rebound or recurrence of disease activity. And it was less impressive with the rituximab or ocrelizumab. But again, not a randomized trial, and again, not remotely the same population as in ours, in our DISCO-MS study. So there are several factors that could be related to disease recurrence. Should you de-escalate or should you discontinue medications as you age? And the factors are going to be age, older is better, time from disease onset, longer is better, recency of disease activity with either a scan change or a relapse, longer time is better, and possibly the actual drug that you're discontinuing. When other studies, observational studies, have looked at people coming off of, especially Gilenya, there have been numerous studies which have looked at this. The number one factor associated with risk of disease recurrence, typically a relapse, is age in multiple studies. So the older you are, the less likely you are to have recurrence should you go off of Gilenya. So again, there's no perfect age for that, but you might be a little bit more cautious, either de-escalating or especially discontinuing either Gilenya or Tysabri until you are perhaps even a little bit older than 60. The other thing you can do, though, is you can de-escalate drug. So as opposed to just stopping Tysabri or stopping Gilenya, you could convert to another alternative medication. So still stay on medication, but maybe take one that has a lower risk. Again, maybe a fumarate or something like that, Tecfidera or Vumerity, one of those drugs like that would potentially be one option to maybe reduce risk, especially. I think that answered a lot of questions about all of the aging related issues, and especially to reinforce that there are some potential benefits to going off drug, less infections, better vaccinations, especially if you come off anti-CD20 drugs. But there are potential risks with recurrence of disease activity. So we always continue to monitor, sometimes even increase our monitoring if someone does a de-escalation or a discontinuation trial. So another related question is for people either who have been off drug or maybe even never used drug, and they're having worsening problems, say with their walking especially, maybe being the most common as they're aging. What do you do about that? Should you go back on a medication or should you use medication for the first time? Perhaps, but also as you age, there are many other comorbidities, other conditions that we have to be concerned with. And when it comes to walking, there are some obvious ones. So do you need to have your knee replaced or your hip replaced? Do you have spine problems? Do you have lumbar disc disease? Do you have a herniated disc in your lower back that's affecting your walking? Or maybe you have some stenosis, some narrowing. So if this is your spinal cord and your spinal cord is going down through the spinal canal, that canal can get narrowed over time with bone and disc that can squeeze your spinal cord, and you could have problems related to that. So the important thing, especially as you age, is to make sure we pay attention to other comorbidities. You could have worsening gait because you've developed Parkinson's disease. And we certainly don't want to treat your Parkinson's disease with medicines for MS. So you want to be very careful to make sure we consider other things as people age that can absolutely play a role in how you walk, or maybe have bowel or bladder function, or maybe have vision. Vision's a very important one. As you age, you can have perhaps glaucoma. You can have a torn retina. You can have floaters. You can have any of a variety. You may have to have your cataracts removed. So glaucoma and cataracts are big ones as people age, and you don't want to miss those because those are treatable and are treatable differently than treating MS. So as you age, comorbidities become much more important than they are in, say, a 25-year-old. And so that's another big take-home message. Don't forget the other stuff. Don't blame MS for every problem that you have. There's some data, might be published soon, that's looking at whether or not there is an actual decreased risk of Alzheimer's in MS patients. And there is some data that supports that. Needs to be confirmed by others. But it's always been a question, for example, as people age, if you have more problems with memory, more problems with losing your keys, forgetting people's names, other things like that. Is that just MS? Is that aging? Is that both? Or is that just another condition? And we always have to keep an open mind as a neurologist, saying, hey, we got to think broadly. We have to make sure that we're not just blaming MS for everything. We want to make sure we investigate the other alternatives. And in my experience, the biggest alternatives that are most common are knee problems, hip problems, spine problems. It's not very common that we see someone with Parkinson's disease and MS. I've seen patients with both. I've seen both with Alzheimer's and other things. but those are just less common. It's much more common to have the super common things like disc disease and spinal stenosis and other things, or just plain need your hip replaced. So those are very common. We have to make sure that we're always looking for the other things that could be going on. I'm going to take a look and see if we have some questions that I sort of didn't actually get to from the audience tonight. Let's see. So the question from Tom that I asked before, what are you talking about? Thank you very much. So Tom asked a question. Right now, Ocrevus is only given in an IV form. Kesimpta, in the same class, ofatumumab, is subcutaneous. However, the Ocrevus trials in Ocrevus patients, so it's Ocrevus, but it's not given by vein, it's given subcutaneously. You would still actually go to a center where someone would actually inject you, as compared to Kesimpta, which you do at home with an auto-injector with a boom, very brief, very fast subcutaneous injection of a low dose of Kesimpta. The Ocrevus trials are finishing. So far, the reports are that it looks safe and effective. We haven't seen anything published as yet with Ocrevus in a subcutaneous form. We'll see if it gets approved by the FDA. It's not approved by the FDA at this time. And we're always looking for other options. But to me, this again falls into the category of a better mousetrap. We have a lot of mousetraps for treating relapsing MS. I'm not sure this is going to have a big impact. You're still going to have to go to an infusion center. You get the to get the injection, so not an infusion, but somebody has to actually inject you. It is true it's less often the Kesimpta, but the Kesimpta injection is super easy. It comes with a very slick auto injector. So I don't know that it will be much of an improvement. There'll be certainly less injections, but you have to go somewhere to do it, and it takes longer, and it's not clear that that's going to be better than just doing the Kesimpta at home. We're always happy to have other choices, and so we're happy to have anytime we have a new choice. But what we need is stuff for secondary progressive MS. And Jane asked a question, is there any hope for an effective drug for secondary progressive MS? And the answer is yes. And it depends on how you define effective. There's one thing to be neuroprotective, stop the nerve cells from dying, but that doesn't improve you. It's one thing to slow the progression of disability. That's good, but it doesn't improve you. It's another thing to remyelinate the nerves. Those might be associated with improvement, but they have not shown it yet. So we need drugs that, well, drugs or devices or approaches, not just drugs necessarily, that can regenerate nervous tissue, not just stop relapses. We need to actually fix the problem in the nervous system once damage has occurred. And so the ultimate way to do that, of course, is to never have MS occur. And so one thing that could be relevant to that, many of you are probably aware that there's a clear association between Epstein Bar virus and development of multiple sclerosis. It is probably necessary but not sufficient by itself to cause MS. But if you could stop Epstein Bar virus infection with a vaccine, then that would potentially put the kibosh on MS altogether. Now, the problem is the following. One, it's only been the first Epstein Bar virus vaccine trial began January 6th. Yes, that same January 6th of 2023, I believe. And it's going to be ongoing for a while, but the main outcomes are going to be whether or not you actually convert. So you have to take all people who are negative for Epstein Bar virus exposure. So these are going to be kids. And then you're going to give them the vaccine, give half the people the vaccine, the other half don't get the vaccine. And then you're going to see who converts, that is, who develops a vaccine response. And then you can measure things like who gets, how many people get mononucleosis, which is related to Epstein Bar virus. And that's fine. Those are great. They're important outcomes. But in theory, you might not get MS for years after being exposed to Epstein Bar virus. And that is not one of the primary outcome measures of these vaccine studies. So it's not 100% clear until we actually have a lot of people getting vaccinated, or until we have vaccine studies with Epstein Bar Virus, where the outcome is looking at MS, or even looking at lymphoma, which is also associated with Epstein Bar Virus, especially Burkitt's lymphoma in Africa, for example, definitely associated with Epstein Bar Virus. Until someone looks, long term at the impact over years, we're not going to really have the answer. So we may look up, if, let's say, Epstein Bar Virus vaccine gets approved maybe 5 years from now, just for argument's sake. And then let's say, which is challenging in the present environment where there are many people that don't believe in vaccines or don't trust vaccines. But let's just say, miraculously, we have many people who get vaccinated for the Epstein Barr virus because it's safe and effective. Let's just say that's true. We don't know that yet, but let's say it is. Many people get vaccinated. We're going to have to probably wait 5 to 10 years to see if we have a drop in new cases of MS. And so it's going to be very difficult to do that. But ultimately, the best treatment for MS is to never get it. And right now, the best shot probably looks like looking at very, very early MS and trying to identify the very earliest triggers, what particular genes are associated with the earliest triggers, what exposures like Epstein-Barr virus, or maybe there are toxins or other things, low vitamin D, smoking, any of a variety of other things that we know are risk factors. Modulating all those things and coming up with a vaccine for Epstein-Barr virus may be our best way to halt the development of MS altogether. But for secondary progressive MS, for primary progressive MS, I remain quite optimistic, but at present, we don't have anything right now that is proven to be for people with inactive progressive MS that is not associated with a recent relapse or scan change. The medicines are just unfortunately not very effective. So there's a question there. Is it recommended to spread out Ocrevus infusions if you have stable MS? That's going to be a very individual decision, but I described some of the options. The times that I would view that you would be effectively wanting to consider that would be one in a younger patient who you want to use, let's just say Ocrevus, rituximab, either one, Briumvi. You want to use that for a long time in a younger patient. They've had maybe 6 doses. They are stable. They don't have progressive disease. They don't have any recent relapse or scan change for at least several years. And maybe their antibody levels are starting to drift down just a little bit. That to me is a target audience for considering extending the dosing interval out to 9 to 12 or even longer number of months. Another population is people who are perhaps a little bit older. And if you're a little bit older, you may not need to use the drug as long, but you may be also dropping your antibody levels a little bit faster. And when you are older, those antibodies don't come back as fast. They just don't when you stop the drug. So an older patient who's relatively stable as well, hasn't had a relapse or scan change for a while, de-escalating by extending the dose totally makes sense to avoid risk of infection with a drop in your antibody levels. But that's really, we're oftentimes sort of forced to do that because their antibody levels after using the drug for many years, could be problematic. We've been using almost exactly now for 7 years Ocrevus, but we used rituximab for 8 or 9 years before Ocrevus, and we still use a lot of rituximab. So we have some patients who've been on rituximab and or ocrelizumab for 10, 12, 14 years. They have a substantial risk of their antibody levels drifting down over time. And if we can buy them another year, 2, 3, before we maybe do a trial off medication, say when they're 60 or 65, then that is well worth it to extend their dosing out in that context. So it's going to depend on the individual. We oftentimes do not do extended dosing intervals in people with progressive MS because there is some data that we may be actually with progressive MS underdosing with either rituximab or ocrelizumab. This comes from ocrelizumab, the phase 3 trial, the Oratorio trial with primary progressive MS. And it's in part related to size. That is, there's data from the phase 3 trial with Ocrevus in primary progressive MS that the people who did the worst were the people who were bigger. And so we may be underdosing, especially larger individuals, and there may be more benefit to gain. That is, we may not have reached the ceiling on potential benefit with progressive MS with Ocrevus. And so that trial is ongoing, looking at even up to doubling the dose of Ocrevus and doing it based on size. And so we should have data from that, I think, about 2 years. And if we have data that shows that potentially increasing the dose, so not extending the dosing interval, but actually using more, especially in larger individuals, then that would further personalize the approach to using Ocrevus, maybe using it, especially in progressive patients, and especially in larger progressive patients, using a higher dose. So that remains to be seen over time. So again, it's individualized. All right. Let's look at a couple of other questions we have here. Let's see how much time we have left. We have about 9 or 10 minutes left. So we talked about all that. There's some questions that were somewhat smaller questions that didn't have to do with aging and things. Let's see. Talked about that. There were a couple questions about differences in Europe compared to the United States with regard to access to medications. Actually, I would say in a broad picture, 50,000-foot view, our access to medications in the United States is actually much greater than it is in Europe. In Europe, most of them are national health systems, governmental systems. There's some private systems. There's sometimes a mix, like Germany's a mix. I think Spain is a mix as well. But access to the drugs is very limited with strict step edits, where people have to fail multiple drugs. Like I mentioned, that study from France that looked at the more highly effective drugs and going off of them. The reality is that to get to those highly effective drugs, you have to fail multiple drugs and develop more disability. In the United States, we have insurers who are limiting access, and they are the ones imposing these step edits. But we have been much more successful, I think, at getting around those step edits and really forcing our way as physicians to say, we want to use more highly effective drugs earlier. And I think we've done a much better job. And talking to my friends in Europe, I mean, it's like set in stone. You cannot get access to these medicines unless you've clearly failed other medicines. We can oftentimes get past that simply by jumping up and down like our hair is on fire when we're talking to insurers. But we happen to be right. The data is overwhelming at this point in time that when you are newly diagnosed, that you will do better if you start on a more highly effective drug then. That is your greatest risk period. It has the greatest impact at that period of time, and you simply do better, at least in the near term, out to 5 to 7 years, if you use more highly effective therapy. Now, can I say that at 20 years there's a difference? No, we just don't have that data yet. But we do much better than that in the United States than they do in Europe. There was a specific question about the use of stem cell therapies, and I think someone got some misinformation. I'll just read the question. Why doesn't the US fund stem cell transplants as the first line of defense against MS? The UK is far advanced and uses this treatment first. The cost of this treatment is also $200,000 less in Mexico. Stem cell transplants need to be at the forefront in treating this awful disease. And then talked about Selma Blair and other famous people with MS who get access to this because they can essentially buy it. There are a lot of statements there that I don't find to be accurate. Number one, the UK is not far advanced. It is true that in Europe, a number of studies have been done with stem cells. The best stem cell study so far is probably from Canada, actually, out of Ottawa. But there have been many stem cell studies in the United States. I participated in them for the last 20 years. And so there are many stem cell studies in the United States, Canada, and Europe. And what they have all shown is essentially when you're using bone marrow derived stem cells, because that's what we're talking about here, it's the same thing. when people are younger with active relapsing MS, they benefit. And we wrote a paper, I think it was published in 2019, so 5 years ago, that was directly aimed at insurers to get them to pay for it. And we are much more successful now with insurers getting them to pay for it. We just have to prove that is a reasonable thing to do. If you're going to say, I want to take a bedbound 75-year-old who hasn't had a relapse in 40 years and try stem cells, bone marrow derived stem cells, I would hope that no doctor would support that, but also there's no data to support that. And so it really depends on the population you're looking at. And so we would view it, and we wrote in this 2019 paper, that we view it as standard of care in patients with active relapsing MS who are younger and who had failed, at least one medication. It's reasonable to consider a stem cell transplant, and we do them. And we're doing a large stem cell transplant right now to compare a study comparing high dose immunoablation therapy. That's really the treatment. The treatment is to crush the bone marrow, but to take the stem cells out of the bone marrow first, store them, crush the bone marrow, then give back the bone marrow to rescue your immune system. That's really the process. And we're in the middle of a large study comparing that to most highly effective therapy available that's not stem cell therapy, like natalizumab, Tysabri, like Lemtrada, like Cladribine, like Ocrevus, and other drugs. So that's the study. It's enrolling people now. But nobody in UK uses it as a first-line therapy. It just hasn't happened. And so I'm not sure when that person got that information. The cost is roughly about $100,000 to $150,000. It is true that you can get some kind of stem cell therapy in Mexico for less. It's not $200,000 less because the entire cost isn't $200,000. It's probably anywhere from my patients talking to them as to what they spent when they went. It's about $20,000 to $50,000. Typically depends on how long they're there. You have to count all the costs of going there and staying in a hotel and everything else that goes with that as well. And I would say the thing about going to Mexico depends on where you go and what you get. The treatment, as I mentioned, is primarily the high-dose immunoablation therapy. And so if you do not get that as part of your therapy, you're simply taking stem cells typically out of your blood, and then you're just giving them back. And so doing that, or using mesenchymal stem cells, which some patients have gotten without chemotherapy ahead of time, has not been shown to be effective. So it really depends upon what you're calling stem cells and what you're getting. And there are many, many claims coming out of Mexico from the places that are doing stem cells, unsupported by data. They don't report data. They don't do any studies. They simply give you whatever they're giving you. And sometimes it's very reasonable. Sometimes they're well-trained individuals. Their protocols, when we can get access to them, their protocols are similar to published protocols where people have been doing the studies for 20 plus years now. And sometimes we have no idea what people have gotten. So we do not suggest stem cell tourism. In fact, my partner, Dr. Wolf, has written papers on this and did actually a course at the AAN about it. We've seen patients come back with fungal infections and all sorts of things. It's a risky procedure in the best of hands. And if you don't really know what it is you're getting, I don't think it's a good idea to do that. But just to be clear, it is not first-line therapy anywhere on the planet. And it's true that people with resources sometimes can get them faster. Sadly, that's true for many things in the United States with our healthcare system and outside of our healthcare system. But nobody's getting it first line, not the UK for sure. The UK is actually the single country on the planet that's a developed country that undertreats its patients the most. They are famous for limiting access to medications, specifically MS medications over time. They have something called, oh God, what is it called? I forget what it's a regulatory agency. And when a new drug comes out, they come up with a formulation as to what the cost effectiveness is. And if it isn't cost effective, they won't cover it. So they actually have the worst record of actually treating people aggressively. And so I wouldn't use the UK as a marker of advanced treatment. We didn't get to all of the other studies, all the other questions rather. We got to a lot of them. And so I think our time is up though. So thank you very much for participating tonight. We appreciate your coming. We appreciate your questions. They were excellent as always. And hopefully you'll continue to check in with us periodically with our conversations and with our other studies, educational programs as through the Rocky Mountain MS Center. We appreciate their support tonight. And thanks for getting on and have a great night. Enjoy your summer.
Thank you, everyone. Thank you, Dr. Corboy, for all of your knowledge and for all of your time tonight. We did post a link to our evaluation in the chat, and it'll be in the description of the YouTube video. If you would take a moment to fill those out, I do use those to shape programming for the rest of the year. And then if you enjoy this format, like the Q&A, we have another one coming up with Dr. Alvarez on July 12th. That will be streaming online and also in person in Durango, Colorado. So please make sure you're on our email list or following our Facebook group so that you can get updates on our programming. Thanks and have a wonderful night.
Bye-bye. Bye, Corey.